We can start.
Recording in progress.
2, 1, please start, sir.
Okay, good morning, everyone, and welcome to this master class, which is our flagship program from Cardiological Society of India. Today, I have a pleasure of, I'm Dr. Vijay Bang. I'm professor and head of cardiology. Earlier, I was at JJ Hospital. Now, I'm at Lilavati Hospital practicing as interventional cardiologist, and currently also the president of Cardiological Society of India. So we have Dr. Dayasagar Rao, who he doesn't require any introduction. Everyone knows him. He's a renowned teacher from Hyderabad. And we have two moderators, Dr. Srinivas and Dr. Sandeep Verma. And experts also are there. And Dr. Shailesh is the presenter for us today. I request Dr. Dayasagar Rao to start the proceeding along with Dr. Srinivas and other experts. Over to you, Dr. Dayasagar Rao.
Okay, good morning to everybody. I'm only a convener of the meeting, but I'm basically interested in the clinical cardiology. So I would like to participate in as many meetings as possible. This is a class basically meant for the students and also practicing cardiologists, and one can share their experiences and then coach or direct the youngsters to reach their clinical goals. So with that introduction, can I request Dr. Srinivas to start the proceedings? Dr. Srinivas?
Yes, sir. So I am feel very much honored and privileged by this kind invitation by respected Professor Dayasagar Rao garu and also all other organizers. So at the outset, I would like to record my gratefulness for this opportunity. This is really very privileged opportunity to be a participant in this masterclass session. And we have a very interesting case of a cyanotic congenital. I was told that it would be a focus would be on a clinical discussion of cyanotic congenital heart disease. So keeping that in view, we have allotted a cyanotic congenital heart disease kit with some interesting clinical findings. And I request Dr. Shailesh to start his clinical presentation. Shailesh.
Sir. Good morning, all respected teachers. And with your due permission, I will start sharing my screen, sir, now. Sir. I hope my screen is visible to all, sir.
Yes, it is clearly visible. Please go ahead.
Thank you, sir. So beginning with the case for today, sir. Presenting the case of a 5-year-old female child, sir. Farheen, she is a resident of Jagtial, belonging to low socio-economic status. The history has been given by the patient's mother and the history is reliable. The patient has presented with the chief complaints of bluish discoloration of fingers and lips from 3 months of age and history of cyanotic spells from 3 months of age. Coming to the history of present illness, the child is born through full-term cesarean section delivery. The child cried immediately after birth and had no feeding difficulty, and there was no history of prolonged hospitalization at the time of birth. The child was apparently well till 3 months of age. At the age of 3 months, the parents noticed bluish discoloration of the fingers as well as the lips at the same time. Also, there is history of episodic deepening of blue color of the skin and lips observed from the age of 3 months, which mainly happens when the child is crying or feeding, and as there is associated history of increased rate of breathing, and these episodes usually get relieved after the mother holds the baby with legs folded against the chest. The patient was taken to a hospital at around 4 months of age, where she was diagnosed as having some heart disease and was advised surgery for the same. but they did not follow. Also, at the hospital only, the doctors had advised the parents to hold the baby with the legs folded or to make the child sweat whenever the child feels breathless or there is increased deepening of the bluish discoloration. These episodes lasted for about 2.5 years of age and then subsided. However, the bluish discoloration of the fingers and lips persisted. There is attainment of milestones at the appropriate time. There is no history suggestive of recurrent lower respiratory tract infections. No history of persistent generalized fatigue. There is history of persistent generalized fatigue is present. No history of chest pain, palpitations. No history of blurring of vision, neck stiffness or weakness of any limbs. There is no history of long-standing fever, skin lesions or blackening of fingers. There is no history of lower limb ulcers, abdominal pain, giddiness or headache, and there is no history of swelling of feet, anorexia and vomiting. In past history, there is no history of other comorbidities and no history of cerebrovascular accident or prolonged fever in the past. In personal history, the patient takes a mixed diet. However, the appetite is decreased. There is poor weight gain. The bowel and bladder habits are normal. In family and antenatal history, the patient is first child of a non-consanguineous marriage, having a younger brother who is normal. The patient is born out of cesarean section at full term, and there is no significant antenatal or postnatal history in the mother. To summarize the history, we have a 5-year-old girl child who presented with history of cyanotic spells and squatting episodes and associate from 3 months of age, and there is associated persistence of the cyanosis from the age of 3 months.
Sir, can we start some discussion on the analysis of the history, sir?
Dr. Shailesh,
Sir,
see, what is the importance of cyanosis appeared at 3 months of age, actually? You specifically told it started at 3 months of age. What is the importance for that? How the history and clinical data favors or support at 3 months of age cyanosis? What is the importance?
Sir, mainly the beginning of cyanosis at around 3 months of age, sir. It indicates that because of the growing infant, there are increased metabolic needs of the infant, sir. And associated, there is a fall in the levels of fetal hemoglobin, sir. And if there is RVOT obstruction, sir, so there can be increase in the severity of the stenosis, sir. So also importantly, there can be functional as well as anatomical closure of a patent duct, sir. So these all features can lead to the appearance of cyanosis at around 3 months of
That reason, what you told is absolutely correct. These are the 4 reasons where the cyanosis will be deferred. So we call it as whenever there is a VSD-PS physiology. First of all, when the cyanosis appeared over the period, that suggests VSD-PS physiology first. Or second thing, admixture lesion which not presented by chance at the beginning and now they are presenting. Okay, but mostly it's a VSD-PS physiology which present, and why it's present late, what you summarize. So that is known as a deferred cyanosis. That's what a deferred means. The cyanosis deferred not from the birth but present after 3 to 6 months of the age because of all the reasons what you told. Some of the same patient presented with the cyanosis at birth. What may be your thinking process in doing the assessment actually?
No, Shailesh, you understand what that Sudeep has been trying to drive home? What for his question, you see what he has very genuinely appreciated your answer. But then what he has added to that is very important.
Yes, sir.
The approach to that question should be, the answer should be like this. I feel from this history, because of the cyanotic spells and the squatting episodes, the child is having VSDPS physiology.
Physiology.
Among VSDPS physiologies, it is the top which is most likely to present a little late after birth, though the setting is there for cyanosis right from birth, but still it will manifest late because of these reasons. That's how you should have answered. But anyway, the reasons you gave are perfectly correct.
Perfectly correct.
Okay, that's what he has very gracefully corrected your answer. Okay, you got that point?
Yes, sir.
Okay. Now he has asked you, what would be your thought process if this child were to have cyanosis right from the day one of the birth? Isn't it so, Dr. Sudeep?
Yes, sir. Yes, correct, sir. You put it in a very good frame, sir. I am not able to present a good frame. But what the same patient, if the cyanosis from the day one or initial days of the life, what will be your thought process actually? What do you think of?
Sir, if in a case of a VSD PS physiology, sir.
No. It's not about VSD PS. If I ask a specific question, VSD PS, so you told what sir told how to present that it because deferred. That's what you are telling. It's a top VSD PS. If somebody presented with the cyanosis right from the birth, so what may be the causes? I ask you directly like that. Don't stick only to VSD PS.
He is asking what are the causes of day one cyanosis. That's all.
That's all. In a more simplified way.
Mainly in transposition physiology, sir, patient can present with cyanosis on the first day of birth.
Please be very crisp and crystal clear in your answer. Why don't you say DTGA?
Yes, sir. Complete transposition of great arteries, sir.
Correct then.
Or even in cases of admixture physiology, sir, also patients can present with cyanosis at first day of life, such as patients who are having a total anomalous pulmonary venous connection, sir, or in patients having either a single atrium or a single ventricle, sir. These cases, or in cases of truncus, sir. These are the situations where the patient can present with cyanosis on first day of
Apart from that, we'll correct or we'll discuss among that. What are the other? This is one set. You told admixture lesion. So that is complete of inadequate admixture, complete admixture. Incomplete admixture is the term which is used for TGA, where the ASD and PDA is essential for survival. So that is one, which is the most common cyanotic heart disease at birth is TGA. Then other admixture lesion you told, TAPVC, mostly they will present when they are obstructed. Mostly unobstructed, they may not able to present because they know an obstruction, so they may have fairly in a good saturation, which we're not able to detect from our clinical examination although, or the other admixture you told. What is this is one set of the substrate you told admixture lesion, incomplete or complete admixture. Second set of the lesion which can present with the cyanosis at birth. You already told out of VSD PS physiology, what are the lesions which can present at birth?
Sir, in VSD PS physiology, sir, if a TOF is associated with critical pulmonary stenosis or there is pulmonary atresia, sir, and there are no proper aortopulmonary collaterals have not formed, sir. So in such situations, when there is a markedly decreased pulmonary blood flow, sir, these cases can present with cyanosis early.
Okay. So, complete the list. One is like, okay, TOF with pulmonary atresia can sometimes present with day one cyanosis, not always. Okay, as you have qualified that statement. Then anything else in VSDPS that Sudeep has asked?
Even
VSDPS, the prototype is TOF, which as just now we discussed, it will present usually little later after birth. But VSDPS conditions which present very early after birth with cyanosis. One is pulmonary atresia. Anything else? Tricuspid atresia PS?
Yes, sir. Even tricuspid atresia, sir, can present.
Single ventricle PS?
Single ventricle PS.
Single ventricle.
Pulmonary atresia, intact ventricular syndrome, all these things there. Then hypoplastic left heart syndrome, other conditions of day one cyanosis are very early after birth. There can be cyanosis. Okay.
Yes.
So what you told at the history, because you told very specifically history is from 3 to 6 months. The same history from the birth, then your set of the substrate, you think over that and your thought process will be different. And now your thought process is different.
Yes.
So that's what it's important to know that early onset of cyanosis, late onset of cyanosis. Okay. So that is the thing. Okay. And you told specifically the episodes of knee chest position and squatting. What is the importance of that?
Sir, these are the typical, sir, episodes of cyanotic spells, sir, which in history.
What is the most common age of cyanotic spell presentation? Mostly when it will present?
Sir, mostly cyanotic spells, they occur after prolonged deep sleep, sir, when the child wakes up.
So means what is the normal age usually? Which
Sir,
age
usually these cyanotic spells, most commonly they present between 2 to 6 months of age, sir, and up to usually 2 years of age they occur, sir.
Usually most common it's in infantile age, correct? But why is it so?
Sir, the major reason is the immaturity of the respiratory center, sir. The respiratory center is more vulnerable to changes in the blood pH and oxygen and blood partial pressures of carbon dioxide, sir.
One, what you told correct, because as the brain maturity develops, the spells will become less and less. Second thing, the child will automatically, once they grow, they try to compensate. They won't go up to that level to present with spell. They know how to prevent that spell. So there are one or two reasons which we can tell you the spells are most common, but the most common is the immature center. That is correct. Okay. So how you differentiate whether this spell is whether this cyanosis is related to the VSD-PS spell or whether it's related to the distress or any. You understood? If suppose any breathing difficulty, whether this because of the VSD-PS or any admixture lesion, how you would decide? What I want to tell you, what is the typical course of spell? How you differentiate from the other causes actually of the cyanosis? You can make it out.
Sir, in a typical course of a cyanotic spell, sir, after the child wakes up from a deep sleep, sir, and if the child either cries or on
what you
feeding,
told correct, what substrate is there actually?
Yes,
the
sir.
typical history will be there. Okay, then setting of that. Okay, when the child cries, the typical is there. In cyanotic spell, there will be only the tachypnea will be there, and that only with the inciting event. That's how you differentiate. Suppose if you do the admixture, there will be distress continuously throughout when the lungs are flooded with the blood. So the typical spell is only the deepening of the breathing. Only the rate is increased. Or deepening of the breathing will increase, but there won't be any intercostal retraction. There won't be any cough usually. Okay, while in the same admixture lesion where there is an increased flow, like TAPVC, truncus, or any other where the more flow to the lung, you will see the intercostal retraction, there will be cough, there will be continuous tachypnea breathing, or so that's what the history of the spell is quite having the deep and only rate of the breathing increase, not the work of the breathing increase. So that is the typical of known as quiet tachypnea. Quiet tachypnea is because of the acidosis which we happened during the spell episode. So that's how you able to differentiate, because the specific inciting event like crying or deep sleep and all come out of that, and then it started, and then it will be only work of the breathing won't increase, only the rate and depth of the breathing is increased. So that's how you differentiate clinically from the other actually other admixture lesion, other reason. Okay. Any other place where you will find out spell apart from VSD PS physiology? Not in this age, but any age, squatting or
sir, in few cases of VSD with Eisenmenger, sir.
Why is it happened?
Sir, because like the physiology is almost identical, sir. If in a VSD, once it goes
Correct,
into
because it's a physiological obstruction. So then once you go, the blood try to go to the less resistant zone. So once in the VSD or any Eisenmenger, the pulmonary pressures are high, so it will go towards the systemic side. So they will develop as a spell or giddiness. Like so, it's correct actually. Okay. Anything sir you want to add, sir? Srinivas sir, Saki sir. So
Other moderators are there, Dr. Dr. Vijay Bang is also there, the chairperson.
Vijay sir.
Hello. Yes, sir.
Yeah.
Yeah. You see, it is a squatting which is a little more common in VSD Eisenmenger than spell, so far as the common symptoms between VSD PS and Eisenmenger VSD is concerned.
Yes, sir.
Squatting is more likely.
Squatting, sorry.
Eisenmengeration occurs usually a little later in the life. So by which time the child would have grown out of the age of spelling. But when Eisenmengeration occurs very early, less than 1 year of age, perhaps even spelling may occur.
So sorry, I want to tell that squatting by mistake I told spell that. Sir.
Okay.
So I want to ask the squatting where it's all common. Okay, sir. Okay. So your history, what does it indicate now in short? You told CVA episodes. What are the CVA episodes may happen in cyanotic heart disease? In such case, 5-year-old.
Sir, because of cyanosis, sir, leading to polycythemia, sir, that can lead to episodes of cerebrovascular accident, sir, in such patients.
What cerebrovascular accident in cyanotic heart disease? There are two types. Either it will be, you will get the infarctive pattern or abscess pattern. Or there will be third thing known as the venous thrombosis. Either it's an arterial or venous thrombosis, or there will be abscess. So what are the reasons for that? Why it happened is there is a time frame usually when it happens, and that will also give clue to the type of the CV episodes happened in cyanotic heart disease. Usually CV episodes are more common in lower age. Why? First thing. Secondly, I'll ask in another way. Any medicine you are giving normally to the cyanotic heart disease, normally you will see most of the cardios everyone is giving. Iron we are giving. Okay. Why? What is the purpose of giving iron in a cyanotic heart disease?
Sir, in these children, there is a iron deficient erythropoiesis is there, sir.
So how does it matter? What is the, if you ask one thing, what is the purpose of giving iron in a cyanotic heart disease? So if you see the literature, it's clearly showed the purpose is to prevent stroke. How it prevents stroke? See, the thing you have to understand, see, the normal RBC is a very pliable. It can cross the blood-brain barrier very easily. So once it's an iron deficiency, it will become microcytic stiff. So even they're not able to cross the blood-brain barrier. So that's why one that won't able to cross, it will cause the rouleau formation, it will cause the thrombosis in a brain. So that's why the main purpose of giving iron in a cyanotic heart disease is to prevent stroke first. And in pediatric age group, smaller, the iron deficiency itself a normal phenomena. You will see so many children with 7, 8, 9, 10 hemoglobin without any problem. So in iron deficiency anemia, stroke will increase in presence of your thick blood polycythemia, sluggish circulation. That's what the CVA is more common in the early age. We are giving iron to prevent that. And over the period, repeated episodes of hypoxia, small thrombosis, there is a nidus for infection. That is the cause for the cerebral abscess at the upper age. So cerebral abscess, you see all those usually present little late, but the CVA usually present early in the cyanotic heart disease. Third thing is venous thrombosis also may happen because of sluggish circulation and the thrombosis.
So that is very correct. So usually less than 2 years of age, as Dr. Sudeep has rightly said, it will be more like stroke-related neurological deficits. Beyond 2 or 3 or 4 years of age, it is likely to be a cerebral abscess. And one important point has brought to your attention is it's a combination of polycythemia with relative anemia. That is a deadly thing. Because as he said, normally the RBC is a biconcave structure. A biconcave RBC is more deformable. So that means it can squeeze itself very smoothly through capillary system. But when in the presence of relative anemia, RBC loses its biconcavity, it becomes spherical in shape and also becomes less deformable. So in polycythemia, where RBC load is more and which are not much deformable, there is a bad situation. So they are going to go and clog the small blood vessels. That's how the stroke will occur. You understand? So that's a very important concept he has just now discussed. I'm only reiterating the same thing. Now I request Dr. Dayasagar Ragaru and the chairperson sir to also make some insightful comments and sessions. Sir.
No, as and when required, we will do that. I think the time is running out, so let us concentrate on discussion. And if there's anything more, what do you call?
Then we will go into the presentation of the case, sir.
Yeah, exactly.
Yes, sir. Go ahead with your presentation.
Yes, sir. So based on the presenting history, the provisional diagnosis is cyanotic congenital heart disease.
No, go to your clinical examination.
Okay, sir. Beginning with general physical examination, sir. The patient is thin built and ill nourished, having a weight of 13 kg with height of 97 centimeter and BMI of 13.6 kilogram per meter square. There is no pallor. There is a cyanosis present in all fingers, toes, lips, and oral mucosa. There is pan-digital clubbing of grade 3. There is no icterus, no edema or lymphadenopathy, no dysmorphic features, no peripheral signs of infective endocarditis or acute rheumatic fever, and no neck swelling. In vitals, the pulse rate is 100 beats per minute, regular, normal volume, with no radial or radiofemoral delay, and all peripheral pulses are felt equally. The carotid pulsations are normal with no thrill. The blood pressure is 90 by 55 millimeter mercury in the right upper limb in supine position, 90 by 60 millimeter mercury in the left upper limb, and 90 millimeter mercury systolic pressure in the right lower limb. The respiratory rate is 20 per minute and the respiration is thoraco-abdominal. The saturation is 78% in the right upper limb, 77% in the left upper limb, 79% in the right lower limb, and 76% in the left lower limb. The patient is afebrile to touch. Coming to cardiovascular system examination, the JVP is normal mean column height with normal waveforms and negative abdominojugular reflex, and there is no venous hump. On inspection and palpation, the chest is bilaterally symmetrical, the trachea is in midline, the apex is in the left fifth intercostal space, 1 centimeter medial to the mid-clavicular line. It is an RV type of apex. There is no parasternal heave. Palpable A2 is present, no thrill, no palpable pulsations, and no scar or sinus. On percussion, the left heart border corresponds to apex. The right heart border corresponds to the right sternal border. The left second intercostal space is resonant, and the liver dullness is in the right fifth intercostal space. On auscultation, the first heart sound is single and normal. There is a single second heart sound, which is a loud A2, and it is more prominent in the right second intercostal space. The aortic ejection click is heard in the new aortic area, and it is non-consistent. A grade 3/6 high-pitched crescendo decrescendo ejection systolic murmur occupying 1/3 of systole is best heard at the left second intercostal space with the diaphragm of stethoscope at the end of inspiration in supine position. And there is a grade 2/6 long systolic crescendo decrescendo murmur heard in the back on the left side.
Just two things. Suppose you are telling no pallor.
Sir.
How you assess pallor in a cyanotic heart disease? You told no pallor, no? How you assess? See, sometimes when it's a deep cyanosis, it's very difficult to assess. So you cannot sometimes comment on the pallor. So now the second question comes, how you assess iron deficiency or pallor in a cyanotic heart disease? Clinically, it may be sometimes very difficult. You may not be able to know, but what are the other ways apart from clinical to see the pallor or iron deficiency anemia, because that's an important point in cyanotic heart disease to assess. Any investigations, any blood?
Most important is hematocrit, sir. In
hematocrit will not tell, na, that. Okay. Apart from hematocrit, what hematocrit will be raised only. EC will
Yes.
be raised. So it's a paradox where the hematocrit will be raised, but the iron deficiency is there. So how the iron deficiency you will diagnose in such cases?
By the RBC indices, sir.
Correct. First, what are the RBC indices?
Sir, the mean corpuscular volume, sir.
The first thing. Second thing, what is the importance of red cell distribution weight?
Red cell distribution width will be increased, sir.
So that is the very important point. All the iron indices, peripheral smear, you have to see whether there is a microcytes, pencil. Then at that point only you have to start giving the iron, not in all patients. So that's what the peripheral smear indices, red cell distribution weight, and the total. If you want to do, then it's there. So that is very difficult. So how the pallor affects your cyanosis on examination? Suppose anemia is there.
Yes, sir.
How does it affect your cyanosis on examination?
Sir, if anemia is there, sir, it is difficult to find cyanosis, sir, because once the pallor means the total hemoglobin content itself is decreased, sir. So the amount of hemoglobin needed to produce cyanosis, which is around 4 to 5 grams per deciliter, sir, it may not be there. So even if the child is desaturated, sir, still cyanosis may not be present, sir.
Okay, correct. And you told pen detail grade 3. What is grade 4?
Sudeep, can we just ask him to summarize his findings first?
Okay, sir. Sorry, sir.
Summarize your findings, sir.
Okay, sir.
To summarize, sir, 5-year-old child, sir, with on a general physical examination, a thin built and ill-nourished, with presence of cyanosis and pen digital clubbing of grade 3, sir, and on this vitals, there is a desaturation, sir, in all 4 limbs present, even at rest, with a normal pulse and BP, sir, and with a normal jugular venous pressure, and with on palpation, inspection and palpation, almost a silent precordium is there, sir, with a apex which is of RV type, sir, and there is a palpable A2. And on auscultation, sir, the first heart sound is normal with a loud aortic component of the second heart sound, and audible aortic ejection click, which is non-consistent, with a ejection
inconstant, not non-consistent. It's an inconstant. Okay.
Sorry, non-constant, sir. Sorry, with a ejection systolic murmur of right ventricular outflow tract origin, sir, and with a systolic murmur at the back, most likely from a peripheral pulmonary stenosis, sir.
I have one comment. Dr. Dayasagar, just have got one comment.
Yes.
In your examination, you have written abdominojugular reflex, REFLEX. Is it reflex or reflex?
It is similar to what I have objected to. So is it, do you think it's a, Sir is asking, is it REFLEX or REFLUX?
Yes. It is, it is a, there's no reflex involved there. There's only reflex.
Only regurgitation. You see, it's kind of reflux. You see, when you press it, the blood will reflux back into the jugular system when the heart is failing. So it is not reflex. So it is a grammatical error.
Yes.
And in fact, conceptual error also.
Yeah, that is true. Second thing is, you said the second sound you said is aortic. How did you come to arrive that it is aortic?
Sir, in a patient of
so that's why the best way to say it is probably A2.
probably aortic.
Yeah.
Yes, sir.
True, because of what do you call cyanotic swells, we are expecting a pulmonary stenosis. Can you have a single second heart sound even though there is no pulmonary stenosis? You understood the question, Dr. Shailesh?
Yes, sir.
Yeah.
So what are the situations where you get a single second heart sound with no PS or pulmonary atresia?
Yeah.
Sir, in cases of absent pulmonary valve, sir.
No. There are two AV. There are two semilunar valves. No pulmonic stenosis. Still, the second heart sound is single.
What is the classical example?
Sir, in case of dextroposition of the great arteries, sir, in which aorta is anterior, sir.
No, is it dextroposition or classically L transposition? So more important than that, you have a severe pulmonary artery hypertension and you have a single second sound. What is the situation? Heisenberger VSD.
Heisenberger, sir.
Right? It's Heisenberger
Yes,
VSD. There you will have synchronously both semilunar valves will be closing at the same time because of equalized hangout intervals, because of high PVR and non-restrictive VSD. Both ventricles act as a single chamber. So you'll have single second sound there. That is one example. Now you can also say L transposition, where even if there is no PS, pulmonary artery being posterior, you may not be able to hear the P2 component of the second heart cell. Okay.
Yes.
Any other examples?
So the implication is, if you find a single second sound, there can be only one semilunar valve, or there can be two semilunar valves, because one semilunar valve is far posterior. Pulmonary pressure is lower. So pulmonary valve may be present, not stenotic, but still you are not able to hear it. So it is malposition of the, or there may be only single semilunar valve. Can you think of conditions where their pulmonary blood flow is maintained, but still there is only single semilunar valve?
You have told one condition, no, when Dakshadeep asked you early causes of sinus.
Sir, in a truncus, sir.
Yeah, truncus. So it is important to remember that, I think you should not overinterpret the data. Just say that second heart sound is single, probably A2.
Probably.
Because there is signs of VSD pulmonic stenosis. Okay.
Yes.
I think there are some, by your interpretation, because you said reflex, I thought probably there is a misunderstanding of the whole concept. Okay, go ahead. So how do you summarize it? No. Second thing is, I just wanted to know, how did you arrive that this was a right ventricle? Apex, you said, is right ventricular.
Sir, it is a diffuse kind of an apex, sir. It is not localized to the like a left fifth intercostal space, sir.
Are there any epigastric pulsations present? Not present.
No, sir. Epigastric pulsations are not felt, sir.
So usually in a child,
Yes, sir.
And there is RVH, you expect epigastric pulsations.
Epigastric pulsations to be present, sir.
What sir is asking, how do you differentiate LV impulse from an RV apex impulse? What are all the points of differences? One, you said it is a diffuse, RV impulse is diffuse, LV is localized or circumscribed. Any other points? Another sir has already told epigastric pulsations go in favor of an RV impulse.
Yes, sir.
Third point.
Is there any traction anywhere in the chest?
Yes.
Where is it?
Sir, lateral retraction, sir, immediately lateral to the apex retractions may be present, sir.
Where? In case of?
RV type of apex, sir.
Exactly.
Okay, go ahead. I think probably it is important that, as I said, you should not overinterpret the data. Probably if you say RV apex, you are going to rule out some other conditions.
Okay, sir.
Tell me conditions of congenital cyanotic heart disease where there is no RVH.
Sir, in cases of tricuspid atresia, sir.
Any other condition?
In cases of single ventricle of LV morphology, sir.
So if you write that RV apex, then are you going to rule it out tricuspid atresia and single ventricle of RV? So I think unless you are very much convinced, is there a parasternal heave present? Not present.
No, sir. No parasternal heave is there, sir.
So if you say the apical impulse is right ventricular and parasternal heave is not present, is it possible? You may not have any pulsations in the pericardium. You may not be able to feel the apical impulse properly. For example, classical tetralogy of Fallot. Although there is RVH by all counts, echo, ECG, and other things, you don't feel any parasternal heave, nor were there any evidence of what you call so-called RV apical impulse.
Yes.
But here you're telling it's an RV apical
RV type,
impulse.
okay.
And then there is no parasternal heave. So I think both are contradictory. So you have to be very careful about interpreting these physical signs. Actually, physical signs are such, the evidence-based physical signs are very few. So maybe we should, that's the reason why I said you should not over-interpret the clinical data. Okay, go ahead. Please go ahead.
One more comment, sir. See, sir,
Yeah.
you just told me there's a liver dullness. Okay, but you have to tell about stomach tympani. Suppose you are not telling, you told correctly liver, but you always comment on the situs from your examination also. See, there is a stomach tympani on the left side and the liver dullness on the right side. Liver you told, that is correct. Second thing, in sometimes if you give importance to your oral hygiene also, in examination, that also itself carries so many things. Suppose your dental caries are there. So that also sometimes we used to include in our clinical examination. So there are the two things. We just want to.
Go ahead.
What is the importance of JVP? Suppose the same substrate, JVP is normal. So what does it indicate actually?
Sir, normal JVP indicates normal RV filling pressures, sir.
So here it's a RVH is there.
Yes, sir.
RV filling pressures are high, but still JVP is normal. Why? No
Sir,
prominent AVOs, nothing.
Because the RV pressures can never exceed systemic pressures.
Why? Why?
Sir, because of the overriding of the aorta, sir, and a
No, not because of
non-restrictive
overriding,
ventricular
because of the presence of VSD.
Yes.
So non-restrictive VSD.
Oh. So JVP will increase only when the RV is unable to decompress. So in spite of severe RVH pressure hypertrophy, it will go beyond that because of the decompression. So when it's a JVP is increased in such cases, that has got typical importance. Either severe AV1 regurgitation is there, or the VSD is not there, or there is some tricuspid edema where you will get whether ASD is restrictive or P intact IVS. So you can tell like that. So suppose JVP is normal, that means the RV in top physiology is able to decompress well so that it will not cause increased JVP or any other prominent component actually.
So and conversely, when do you get elevated JVP in a TOF patient?
Sir, JVP can be elevated in cases of TOF if there is a presence of a restrictive ventricular septal defect, or more commonly if
What is called?
the ventricular septal defect is partially closed by the septal leaflet of the tricuspid valve.
Lap valve VSD. Lap valve VSD. Okay. Then that is one.
Or in situations where the systemic vascular resistance is increased, sir, such as in cases of hypertension, sir, or if the patient has acquired aortic stenosis, sir, thus increasing the afterload to the RV, sir. So that can.
And finally, when RV starts failing in late stages, in adult TOF patients, these patients can JVP may be elevated. RV fibrosis has occurred because of long-standing uncorrected cyanotic physiology. The patient may develop elevated. So if there is a restrictive VSD in a TOF, classical TOF, how will be the clinical findings versus DORB subaortic VSD PS with restrictive VSD? So because it's a very, very close mimic and virtually indistinguishable from classical TOF clinically. So but when VSD becomes restrictive, there are differences in clinical findings. Can you tell?
Sir,
You said no, classical TOF, when VSD becomes restrictive, as Dr. Sudeep has said, when non-restrictive VSD is the egress for the RV. RV decompresses through the VSD. So when VSD becomes restrictive, RV cannot decompress. So it becomes pressure overloaded before. So when it becomes pressure overloaded, all the signs of no RV heave will be there, RV S4 will be there, and there will be jugular prominent A wave and elevation of this. This is classical TOF. And DORB subaortic VSD with restrictive VSD, what will be the findings? Will it be same or will it be different?
Sir, in cases of DORB with subaortic VSD PS, sir, if the VSD is restrictive, sir, then there will be more of the murmur across the
No, I'll put
RB
it
will be
differently.
more audible, sir.
Which chamber is under pressure overload now?
Pressure.
Again, RV or something else?
No, sir. In cases of a restrictive subaortic VSD, sir, it acts as a this subaortic stenosis for the LV, sir, in cases of DORB.
Because VSD is now the only egress for LV.
LV, sir.
RV. So
Yes,
when
sir.
VSD becomes restrictive, it's the LV which is under pressure overload.
Pressure.
So you don't get the signs of RV pressure overload clinically like in top with restrictive VSD. Rather, you will have a LV heave and LV S4 and a long crescendo murmur across the restrictive VSD in DORB subaortic VSD. So there are only very few situations where you will get a murmur of VSD in cyanotic VSD PS physiology. One of which is DORB subaortic VSD with restrictive VSD. The other will be tricuspid atresia with restrictive VSD and then single ventricular morphology with restrictive bulboventricular phenomena. Okay. So please continue. So, sorry, Sudeep. I'm sorry.
No, sir. It's good, sir. I was about to ask you. Asked good, sir. So just one thing. What is the relationship of murmur with the cyanosis here? You tell it's a severe cyanosis. You are telling it's a 3/6 murmur. So what is the normal relationship of murmur with the cyanosis in such cases actually?
Sir, usually with the increasing severity of cyanosis, sir, the length of the murmur mainly decreases, sir. And in severe cyanosis, sir, even it becomes soft as well, sir.
Okay, the third question what sir already answered. There are few conditions, even with the severe cyanosis, the murmur is very long. So what the sir told clearly, like that DORV VSD, restrictive VSD, tricuspid atresia, sometimes single ventricular TGA VSD, PS, where in spite of severe cyanosis, there will be long murmur. So normally in the top physiology, the murmur is short and severe cyanosis will be there. But in spite of severe cyanosis, long murmur, sir already told these are the 2-3 conditions which we have to tell. In spite of severe cyanosis, long murmur, you will get it like that. Okay.
Can we have any comments from All India Institute of Medical Science staff? Dr. Abhinay? Okay, we'll go ahead.
No,
We'll go ahead. Yeah.
What is your differential diagnosis for this?
So the clinical diagnosis based on the history and examination is situs solidus, cyanotic congenital heart disease, VSD, PS physiology with the dominant RB, most likely tetralogy of Fallot with left pulmonary artery stenosis, and patient is in NYHA class 2 in sinus rhythm with no signs of infective endocarditis or congestive heart failure.
Would you like to tell differential diagnosis or only single diagnosis?
Sir, even DORB, VSD, PS can have almost a similar findings, sir, both on history as well as examination, sir.
Just one comment, situs solidus you are telling, right? Levocardia also, situs solidus, levocardia, cyanotic congenital heart disease, VSD, PS physiology. Okay. Why you are telling LP stenosis?
Sir, because of the presence of this another grade 2/6 long systolic murmur, sir, in the left side on the back, sir.
Just wanted to ask you,
Sir.
in the setting of low pulmonary blood flow, even if there is a pulmonary artery stenosis, will you ever get a long murmur? The answer is no, because already there is a decrease in pulmonary blood flow. So even if you have got a very tight stenosis, it's very rare for the murmur to be long.
Okay.
Because the murmur is proportional not only to the severity of stenosis, but also to the amount of blood that is flowing. So diagnosis of peripheral pulmonary artery stenosis in a patient with VSD with severe PS has to cause severe cyanosis is going to be extremely difficult at the bedside. I think it can be made more easily by chest X-ray rather than by clinical examination. Okay, go ahead.
Yeah, the short systolic murmur, which is distinct from this, diffusely present across the back of the chest. And the
Yes.
So probably, see, that's why, as Sir has told, you cannot be dogmatic in your presentation of the findings and especially interpretation of the findings. interpretation should be done in a judicious way, taking into all things in consideration, and should be tempered with kind of modesty. When you say, you can say perhaps there is an associated LPS stenosis, then you are safe. Okay.
Yes, sir.
So sir has objected to your being dogmatic about the presence of LPS stenosis,
LPS stenosis.
and that is a very right objection, scientific objection. Understand?
Yes, sir.
Just for the completion, why LP stenosis is common in TOF? Which RPA, LPA, LP is more common in TOF? Why?
Sir, because of opposing blood flow in the left pulmonary artery, sir. One is from the RV output, sir, and the other one is from the PDA, sir. So there occurs a watershed zone at the...
No, not like exactly like that. See, normally which PA is in line with MPA normally, in normal heart?
left, sir.
Left. So MPA blood flow more towards the left and RPA comes as an angulation.
Yes,
But
sir.
in TOF, because of the clockwise rotation of overall heart, the RPA is in more line with the MPA. So because of that, in spite of, there are so many cases where in spite of equal pressures, LPA flow will be low because of the streaming of MPA towards the RPA. This is the first. Secondly, because of the ductal theory, usually PDA inserts at the LPA-MPA junction. So whenever it gets stenosed, because of the ductal tissue on the left side, it will also get stenosed. So one is because of the physiological reason, which is causing the clockwise rotation, more flow streaming towards the RPA. And second is because of the ductal theory. That's why the usually in TOF physiology, so when you do the cath, you see your catheter will repeatedly go to the RPA in TOF rather than in LPA. In the normal heart, it's the opposite. You will easily enter LPA rather than RPA because of just of the streaming of the MPA and alignment of the MPA to the respective PA.
So what is the incidence of LPA stenosis versus RPA stenosis? TOF incidence.
Sir, LPA stenosis is present in around 3% of cases, sir. Whereas in around 1.5% cases, sir, even there can be absence of the LPA, sir, origin.
So RPA stenosis is how much incidence? Okay, it's much less, about less than 1%. Okay, so even LPA stenosis is very much less, about only 3%, as you said.
Yes.
Of 100 cases of TOF, perhaps 3 at the most can have some LPA stenosis. There is one more reason why you should be little cautious in stamping this as an LPA stenosis. Right.
Got it.
Okay, so what do you want to see? ECG?
Yes, sir.
Okay, go ahead and interpret the ECG methodically in the light of your clinical findings and in the light of differential diagnosis you have discussed.
Sir, this is a 12 lead 4-channel ECG, sir, showing sinus rhythm, sinus tachycardia is present, sir, with rates of around 112 per minute, sir.
First, sir told you should try methodically. You have to read about standardization, speed, which is the rhythm strip. That all you have to comment actually. So if you are telling 12 lead ECG, 4-channel correct with lead 2 as a rhythm strip, what is the standardization? Normal, abnormal?
Normal, with normal standardization, sir.
And speed normal, that then you tell now.
Sir. With the sinus tachycardia, sir, with rates of around 112 beats per minute, sir, with a PR interval of around 120 to 140 milliseconds, sir, with right axis deviation of around plus 120 degrees. With
1 minute. Silas, 1 minute.
Sir.
In congenital heart disease, you want to comment about QRS first or also the P waves? What is the importance of P wave morphology in a congenital heart disease?
Sir, in this case, peaked but not tall, sir. P waves are present in V1 to V3, sir.
Suppose the P wave is inverted in lead 1. What is your conclusion? It is important that you start to interpret the pediatric ECG in a slightly different way from the regular adult ECG, because atria are inverted or non-inverted.
That's what once you are telling sinus rhythm,
Yeah.
You should tell what is the definition of sinus rhythm. It starts from there only. What is
And
the
then-
definition of sinus rhythm?
Yeah. And then the axis of the P wave, that will tell you whether atria are inverted, non-inverted.
Yes.
And you should also tell whether Q wave is present in left ventricular leads or right ventricular leads. These are all important things before you go on to PR interval and QRS duration. Okay, go ahead. Please go ahead.
So, peaked but not at all P waves are present in leads V1.
No. What is the P wave axis, sir? In
Sir,
this
P wave axis is around plus 60 degrees, sir, in this patient.
That is normal or abnormal?
Normal, sir.
Normal. Go ahead.
So what does it indicate?
It
In case of cyanotic heart disease.
indicates the normal location of the sinus node, sir, and the origin of P wave from the normally located sinus
So
node.
RA is on the right side, LA is on the left
Right
side,
side,
and the rhythm
Right
is
side.
generated from the SA node on the right side. So that's what once you call the sinus rhythm. Sinus rhythm means
Sir.
two things, one P followed by one QRs, and the P axis should be normal. If
Sir.
P axis is abnormal, it will never sinus rhythm. So that's why when you are telling P, and the importance of P, what sir told, if the P axis is abnormal, that means SA node is either diseased or it's not present, it's in normal position. So that suggests situs inversus or SA node dysfunction. Okay.
Yes. And there is a
Suppose in this patient, if the PR interval is prolonged.
sorry, sir.
Suppose in this patient, in this ECG,
Sir.
if the PR interval is prolonged,
Sir.
what should you suspect?
Sir, prolongation of PR interval points towards DORB, sir.
DORV. Why DORV? Tell me the congenital heart disease associated with conduction system disturbances.
Sir, conduction system disturbances can be present in congenitally corrected transposition of great arteries, sir. And in cases of a single ventricle, sir, mainly single ventricle of LV morphology, sir, conduction system abnormalities, and even in cases of Epstein's anomaly, sir, conduction system abnormalities can be present, sir.
Associated AV canal.
AV canal defects, sir.
Okay. So these are because the prolonged PR is also important finding when you want to differentiate between the types of differential diagnosis in VSD-PS. Okay.
Go ahead.
Sir, and then there is a right axis deviation, sir, of around plus 120 degrees, sir, and with a clockwise loop, sir. And
what is the importance of clockwise loop in counter? What does it mean? What do you mean by clockwise loop?
Sir, there will be a positive, initial positive R wave in lead 1 and AVL, sir. That indicates clockwise loop, sir. Whereas,
why is the importance you are telling? What do you mean by counterclockwise loop in limb leads? What does it suggest? What does it indicate, actually? Clockwise, counterclockwise loop in the limb leads.
Sir, it indicates the orientation of the bundle branches, sir.
Actually, it's a vectogram finding.
Yes, sir.
How the first initial deflection will go in the limb leads. So that's what, once you draw the vectogram of all leads, then you find out how the vectogram proceeds, whether it's a clockwise proceeding or the counterclockwise proceeding. So clockwise, when it's producing, you will have the Q waves in 2, 3 AVF. And once it's a counterclockwise, then you will have 1 and AVL Q waves. So here it's looks like clockwise. So if suppose it's a counterclockwise, what does it indicate?
See, your answer is not correct. You see, you said because there's a positive R wave, initial positive R in L1 AVL, it is clockwise. No. As Sudeep has said, it's because of the presence of Q waves in inferior leads, it's clockwise. You see the difference. See, these are the Q waves that determine the loop, not the R wave. whatever leads the Q wave is present, initial Q wave, that becomes either clockwise or counterclockwise, depending upon the leads in which the Q wave is present. So now, Sudhir is asking, in the same VSDPS situation, you will have clockwise loop, as you said, in the top. So where will you get a counterclockwise loop?
Sir, in cases of DORB, VSDPS, sir, counterclockwise.
It should be very clear. See, DORB is a huge topic with a lot of permutations and combinations and variations. So you should qualify your statement very precisely. Which type of I'll say DORB subpulmonic VSD with PS or remote VSD with PS. Do you get a counterclockwise loop there?
No, sir.
No.
In cases of
subaortic VSD with PS.
subaortic VSD with pulmonary stenosis.
Where else will you get a counterclockwise loop in VSD?
I'll make the understanding a bit easier.
Sir.
What is the basic mechanism of counterclockwise loop? Why does that happen? Electrocardiographically, why does that happen? Is there any anatomical basis for this clockwise and counterclockwise? Or is it only a functional effect?
Really? So, for instance, if you have a situation where you have counterclockwise loops, what sir is asking, is there any anatomical substrate or basis for that, or is it because of some electrical, physiological abnormality?
Anatomical substrate is present, sir.
What is the anatomical substrate? It's very important to understand this concept so that you will not make these elementary mistakes. Because you're struggling to know the causes of counterclockwise loop. Clinically, let's take endocardial cushion defect versus a ostium primum, ostium secundum ASD. In ostium primum ASD, what is the QRS like? What is the
counterclockwise loop will be present, sir.
Axis?
Axis will be left axis, sir.
Left axis means you have to define. How much is the left axis? -5, -10, -90?
Around minus 45 to minus 60 degrees, sir.
Okay. So why does that happen? So that is important. There is anatomically hyperplasia of the left anterior fascicle. And that often happens only in the inlet type of VSD is there. It won't happen in outlet VSDs. It will happen. So there is an anatomical substrate for this left axis deviation, which is leading to counterclockwise loops. At one time, it was thought it was hemodynamic load that is causing it. But anatomical studies have clearly revealed that it is the hyperplasia of the left anterior fascicle that causes all these things. This hyperplastic left anterior fascicle is a feature of most of these inlet VSDs or any abnormality in the inlet portion of the interventricular septum. So that is the reason. So now if you know that what are the causes of inlet VSD, so you can include all those congenital heart disease with inlet VSD as one of the components are the causes of counterclockwise. Is it clear?
Yes.
Okay. So in this patient, you think there is a left axis deviation or right axis deviation?
Right axis deviation is present, sir.
Mm-hmm. So what is the QRS axis here?
QRS axis is around plus 120 degrees, sir.
And what you already said, you know, how to recognize the counterclockwise and clockwise based on the presence of Q wave.
Yes.
Okay. Is there a Q wave present in V6?
No, sir.
What is the importance?
Sir, presence of Q wave in V6
No. We are not talking about presence. We're talking about absence of Q wave in V6.
Now, where do you get an absent Q wave in V5, V6. Is it not normal to have a Q wave there?
Yes, sir. Normally, Q waves are present, sir.
The absence is significant.
Yes,
So
sir.
in what situation will you get?
So what is the cause of Q wave in V6 normally?
Sir, the normal septal depolarization, sir, from left to right, sir, that causes the appearance of Q waves in V5, V6.
Okay, so why is it absent in tetralogy of Fallot? It is important to realize that although normal conduction of the interventricular septum is the cause, in conditions characterized by low input to the left ventricle, like in VSD-PS physiology, most of the time you don't get a Q wave even though the conduction system is normal. The same patient undergoing a shunt, for example, BT shunt, and then the left ventricle becomes bigger, you suddenly find there is a Q wave. Nothing has changed there. We're not even touching the internal architecture of the heart, but only the volume overloaded left ventricle,
Yes.
which was underfilled, was not showing the Q wave, but when you do a shunt, there is left ventricle input is more, so you get a Q wave. So the causes of absence of Q wave may be a functional, maybe anatomical. Okay, so now if you find a big QRS complex in V6, and there is no Q wave, that's more important. Or conditions in which there is increased pulmonary blood flow, and yet you don't find a Q wave in V6. That is abnormal. In conditions characterized by low pulmonary blood flow, absence of Q wave probably is not that significant. So you need to make a difference there.
Yes.
Okay, go ahead. So is there a RVH present, not present?
Right ventricular hypertrophy is present, sir. There are almost a monophasic R waves in tall monophasic R waves in V1, sir.
So what conditions you can rule out straight away in congenital cyanotic heart disease?
Sir, conditions with LV dominance, sir.
No. We are talking about absence of RV forces in patient with congenital cyanotic heart disease.
Suppose no prominent V1, so what does rule out? That means RV is?
RV is adequately getting filled, sir. And
Suppose if it's present, that means you ruled out small RV conditions like where the RV is absent or very hypoplastic. So you will not get
bicuspid atresia, sir.
Hypoplastic right heart syndrome.
Yes, sir.
Okay, like type of hypoplastic right heart syndrome, tricuspid atresia, or the single ventricle LV with very small outflow right chamber. So like that you ruled out. So that's what Sir was telling, when you got the very good V1, that means the right side chamber is of good size. Okay.
See, the important point here is you have RVH, but there is no significant strain. So this is also important. So there is a RVH because of RVO obstruction, but the septum also is deficient here, unlike PS with intact ventricles. Sir has made a very wonderful, subtle point. I think I would like to re-emphasize that. What Sir has told is, in spite of conduction system being normally placed LVBB on the left side, still you don't get a Q wave in V5, V6 in a top with underfilled left ventricle. This is what precisely Perloff also says. In fact, Perloff gives an ECG example of that and writes in that legend to that ECG diagram that there are no Q waves in V5, V6 because left ventricle is underfilled. This is the point. Sir?
Yeah, that's the same thing, but the same patient undergoing a BT shunt.
Yes, sir. Yes, sir.
And then the Q wave reappears.
See, this is a point which only very experienced teacher like Sir can tell. Okay, you see, this much perhaps people can know, but you see, with a BT shunt, the Q wave will appear. That's a wonderful point. You understand? You have to appreciate this and enjoy this point. So please carry on with your analysis of the ECG. So you have a clockwise loop with right axis deviation, and we have diverged from the discussion of counterclockwise loop examples for VSD-PS physiology.
Yes.
You have said DORV with subaortic VSD and PS. What are briefly, just quickly run through the other conditions which can cause counterclockwise loop with left axis deviation in a VSD-PS patient?
If there is a top with a atrioventricular canal defect, sir.
Okay.
And
What else?
Or else, sir,
Counterclockwise, the left axis deviation, tricuspid atresia, classical tricuspid atresia, type 1B. Okay.
yes, sir.
You have counterclockwise with left axis deviation or not? Then single ventricular valve morphology with non-inverted outlet chamber. What is the problem? That is why Sir has said you should remember the conduction system in each condition, then you can understand these things very easily. Okay, continue. You have done very well in the clinical discussion, but somehow you are faltering in ECG.
And sir, actually there is no transition is not visible, sir. From V1 to almost V5, sir. R waves are dominant only, sir.
Why do you say? Of course, there is some, perhaps, you see, first you should have taken a half standardized DCG. Then there is overlap between the V2 S wave and V3 R wave.
R wave, sir.
We don't know where the S wave is going up to. So perhaps there is some transition. But anyway, even sometimes the transition would have occurred by the time V1 is recorded. In the sense, V3 or V4 or to V1, there can be transition, early transition, or from V1 to V2. So if there is an early transition, what does it suggest?
Sir, mostly it suggests it is in favor of a TOF with pulmonary stenosis, sir. Mainly transition occurs at the level of V2, sir.
So
The predominant
most important to distinguish DVRB subaortic VSD from TOF. So now I want you to focus on these two conditions and give the ECG differences between the two.
Sir, in a case of DORV subaortic VSD,
But complete TOF, all the classical ECG signs of TOF.
There will be RVH with strain pattern will be there, sir, in DORV VSD.
Just now I told you don't get a strain in classical TOF.
Yes, sir.
That's an important ECG sign. Why are you saying there will be strain? Don't get
sir, not in TOF, sir, in DORV VSD.
No, first complete TOF, then go to DORV.
Sir, in TOF, there will be RVH, sir, in V1 without strain, sir. And there will be abrupt transition from V1 to V2, sir. In V2, there will be predominant S waves will be there, sir. And without any pattern, sir.
What will be the usual degree of right axis in TOF?
Sir, the right axis deviation in TOF is around 110 to 100 plus 110 to plus 120 degrees, sir. Whereas in cases of DORV, sir, there is extreme right axis of more than 150 plus 150 degrees, sir.
Okay. Complete other findings of DORV. And
sir, there will be right axis deviation with counterclockwise loop, sir, in DORV, and RVH with a strain pattern will be present, sir. And mostly there won't be a transition will be delayed, sir, at V3 or V4, sir, not at V2.
Broad QRSS in English with slurring of the S wave, L1 AVL, and slurring of export of R wave in inferior. This is also an important ECG feature, QRV. And then prolongation of the PR interval as you have. Sir, if we go to the X-ray, sir, we are already.
Yeah. I think we are running behind time.
Yes, sir. Go to the X-ray.
Sir, this is the chest X-ray PA view, sir, and it is an overexposed film, sir, because all the vertebrae are visible, sir, and slightly rotated to the left, sir. With normal bony and soft tissue shadows, sir. Aortic bubble is not clearly visualized on the left side, actually, sir. But there is a levocardia is present, sir. The apex is on the left, sir, and the cardiac thoracic ratio is around 50%, sir. So there is no cardiomegaly, sir, and there is a right atrial enlargement is present, sir. The right lower cardiac border is formed by a dilated right atrium, sir, whereas the left hard border is formed by the right ventricle, sir. And
no, I have one issue.
Sir.
You said levocardia because apex is on the left side. Is that the definition of levocardia? That does it point out to the presence of apex or something else?
Even in
Thinking about long axis of the heart.
Sir, levocardia, dextrocardia, we mainly describe based on the long axis, sir, pointing from the base of the heart to the apex, sir. What is the direction of the axis, sir?
The simplest thing is major cardiac muscle mass in the left hemithorax is levocardia. Major cardiac mass on the right hemithorax is dextrocardia. What about the abdominal situs? You never commented.
he commented.
Sir, actually, right dome of a diaphragm is elevated, sir. So most likely liver is on the right side, sir. Although
That is totally wrong. That is totally wrong. Are you trying to say that left dome is lower or right dome is higher?
left dome is lower, sir, mainly because of the presence of a heart, sir.
Yeah, that's the reason why you should not be talking about right dome being higher, because tell me one example wherein the liver is on the same side and the diaphragm is also lower.
In cases of dextrocardia, sir.
Dextrocardia, you mean Merrima's dextrocardia? Merrima's dextrocardia, liver is on the other side. What is levocardia? Salish?
Sir.
Yeah. What is isolated levocardia? Heard of the term?
No, sir.
Suppose if the abdominal organs are reversed, but the heart is on the left hemithorax, what do you call that?
That is, sir, isolated levocardia.
So in a patient with isolated levocardia, which dome of the diaphragm is higher?
Right dome of the diaphragm will be higher, sir.
Even though the liver is on the left side.
Yes, sir.
So that is an important example to show that the dome of the diaphragm is lower on the side of the apex, not on the side of higher, not on the side of the liver. How many types of cytosis you know of? You have understood the question? One is
Yes.
situs solitus.
Solitus. Other one is situs inversus, sir. And the third one is situs ambiguous, sir.
Anything else? What is heterotaxy?
Heterotaxy syndromes are, sir, in which...
No, what is heterotaxy? Heard of it?
Yes, sir.
What is it? Not sure. You go and read the chapter in Perloff. It's an abnormal relationship of one organ with the other in the abdomen. So you can have liver on the same side, and then the cecum may be on the left side. So there is a abnormality of the interrelationship of abdominal organs. That is heterotaxy. Okay, go ahead. What about the pulmonary vascularity here?
Sir, slightly actually overexposed film, but still pulmonary vascularity is almost preserved, sir. Normal pulmonary vascularity is visible, sir.
So now you have got a patient with severe cyanosis, and according to you, normal pulmonary vascularity.
That more likely is because of this overexposed film, sir.
Okay, anything else you want to say about this X-ray in a congenital heart disease?
And sir, most likely this trachea is on the right side, sir. There is indentation of the aorta, sir, visible. So there is a left-sided aortic arch, sir. And pulmonary, main pulmonary artery segment is not prominent, sir.
So what does that mean? What is the implication?
Sir, in case of if There is a valvular pulmonary stenosis, sir. So there is usually a post-stenotic dilatation of the.
No, why is this absent here? You're telling that this is a patient of VSD-PS and pulmonary segment is, pulmonary bay is not present, but pulmonary conus is not. So what is the implication?
That indicates decreased pulmonary blood flow, sir.
Or does it indicate the level of obstruction? What will happen, suppose if it is a subvalvular obstruction? Do you expect the pulmonary artery to be dilated?
No, sir. In cases of subvalvular, predominantly infundibular obstruction, sir, pulmonary artery is not dilated, sir.
So that is the reason why pulmonary artery is not dilated. Okay, go ahead. We'll go on to the next investigation.
Echo, sir. The echo report it says, sir, situs soletus, levocardia, 2 atria, 2 ventricles, 2 great arteries with a normal relation of great arteries with a normal systemic and pulmonary venous drainage. There is a large.
One of the, wait. What about the AV valves? How many AV valves are there?
Sir, 2 AV valves, sir.
It is not written down there.
Yes, sir. There is a large non-restrictive
How many semilunar valves are there?
2, sir.
Where is it written?
That line is missed, sir. 2 AV valves and 2 semilunar valves, sir.
Okay.
Yes, sir. So there is a large non-restrictive mal-aligned VSD of size 1.45 centimeter with a right to left shunt with 50% overriding of the aorta. There is a severe pulmonary valve stenosis and confluent pulmonary arteries with stenosis of the ostium of the left pulmonary artery. Right ventricular hypertrophy is present. There is normal biventricular function. There is a left aortic arch with no ASD, PDA or coarctation of aorta and no pericardial effusion, vegetation or clot.
What is your diagnosis from this echo report? How do you interpret this? This is just a narration of details. You have to make a meaning out of it. What is your meaning?
So at the end of the echo, what is your diagnosis?
That's what I know.
Yeah.
Sir, based on the echo, sir, the diagnosis is a cyanotic congenital heart disease, sir. VSD, PS physiology, sir.
No, wait. On 2D echo, how are you going to say it is cyanotic?
No, sir, including the history.
No. We are only asking you to interpret the 2D echo. So based on the 2D echo, you please tell us.
Sir, based on 2D echo, sir, there is a ventricular septal defect with a pulmonary stenosis, sir, and with a 50% override is present, sir. And there is a presence of confluent pulmonary arteries with a stenosis of the ostium of left pulmonary artery, sir, with the right ventricular hypertrophy, sir. So all these features point towards the presence of a diagnosis of a tetralogy of Fallot, sir, with a right to left shunt, sir.
Why is it not DVRV?
Sir, 2 features differentiate mainly, sir, DORB from TOF, sir. One is the presence of aortomitral continuity, sir, in cases of TOF, and other is the extent of the aortic override, sir. Usually in cases of DORB, the extent of aortic override is more than 50%, sir.
But you have there is no mention of the aortomitral continuity or discontinuity in your report. So that is important to mention. So the override itself is not very important to.
Yes, sir.
DVRV is an embryological condition which persists. So it is a structural diagnosis rather than based on the overriding of aorta. So initially, for the sake of definition of a double outlet ventricle, you might make use of the degree of override. But to say whether there is a DORB versus TOF is not the degree of overrate that actually matters, because there are TOF situation patients who will have more than 50% overrate. And conversely, there will be DORB patients with less than 50% of overrate. So that itself alone cannot be the criterion. It is, as you said, the iotometer continuity or discontinuity. So discontinuity means
the presence of there is a symbiotic conus is present, sir.
so it is a DORB. So because
Yes.
DORB will have bilateral bonding. So that is very important omission here in your report, because we have all along been discussing DORB as a differential diagnosis, right, in clinical and ECG, etc. So that should have been mentioned here.
Yes.
So what other information would you like to have from ECHO, keeping in view the ultimate surgical correction?
Sir, for most important, other than the TOF itself, is the presence of confluent pulmonary arteries, sir. For total intracardiac, if the patient has to undergo an intracardiac repair, sir.
What are the
How do
sizes?
you classify? How do you classify high risk TOF patients? Are there any condition called high risk TOF patients for surgery?
Sir, in high risk, sir, are included infants, sir, younger than 3 months of age, sir.
We're not talking about the age, we're talking about anatomical abnormalities.
Sir, in anatomical abnormalities, sir, if there are non-confluent pulmonary arteries are not confluent, sir, there is a either MPA is a atresia is there, sir, or LPA atresia is present, sir. And
Apart from the pulmonary arteries, what are the which makes the surgery high risk?
Difficult. And if there are a presence of a MAPCAS, sir, major aortopulmonary collaterals, sir.
That probably can be managed.
Yes, sir.
But classical high risk features which makes the surgeon nervous, multiple VSDs?
Multiple VSD, sir, if there is presence of AVSD, sir, along with TOF.
Yeah, whatever it is. So you are not telling that, abnormal course of the coronary arteries. So these are the things that you should be looking for. This. So the question asked in the examination will be, is this information sufficient to send the patient for surgery without doing a cardiac cath?
No, sir.
So what is missing there?
The coronary anatomy, sir, mainly the origin and the course, sir. Whether it is the coronary arteries are crossing across the RVOT, sir. That is one information missing. And sir, any information about the collaterals, sir.
So these are all important. So you need to find out. You need to find out, or you need to identify the high risk subset where the risk of surgery will be high. For example, if there is severe hypoplasia of the pulmonary annulus, then, so what is your criteria to say hypoplasia of the annulus and hypoplasia of the pulmonary arteries? Shailesh?
Sir.
What is your anatomical criteria to say hypoplasia of the pulmonary annulus and arteries? You are aware of it or not aware of it?
No, sir. Criteria, I don't know, sir.
Criteria, you are not aware of it. Okay.
You know what is called a Z value of a pulmonary annulus?
Yes, sir. That is the standard deviation, sir, from the normal population, sir. Less than normally it is less than minus 2.5, sir. That is favorable for surgery, sir. Whereas beyond -7, sir, those are not favorable for initial complete intracardiac repair, sir.
And about pulmonary arteries, how do you assess the adequacy of pulmonary artery size for total repair?
Sir, we can use the Magoon's ratio, sir, or the.
And what else? Any index?
Sir, Nakata index is there, sir.
This is what sir is asking. Why do you say?
Yes, sir. So, In Magoon's ratio, sir, we take the ratio of the diameter of the pulmonary arteries, sir, divided by the diameter of the aorta at the level of the diaphragm, sir. Whereas Nakata index is the pulmonary artery area index, sir, in which we take the area of the left and the right pulmonary arteries in millimeter square, sir, and we divide it by the body surface area in meter square, sir, and more than 300 millimeter square per meter square is considered as good, sir, adequate, so that the patient can undergo complete intracardiac repair, sir. Whereas
Nowadays, because that is cumbersome, so we use Z-score for everything, even for pulmonary valve, for RPA, LPA, MPA. Z-score itself is sufficient. So that's what. So that is the importance are asking when your pulmonary valve small, then the coronary artery and it may become more small because you need to do the transcellular patch and you can may damage the coronary.
sir,
So that's what. Magoon Nakata also is there, but that's what nowadays everyone there have got values. So we have to do the Z values for even MP, RPA, pulmonary wall, and that's all. So what do you want to do in this case? Suppose this is your diagnosis now.
sir, actually CT iotogram was also done, sir, for this case. So that is also suggestive of mainly TOF, sir, along with there is a moderate LP.
Do we have those images?
Sir, this is the CT image, sir, which is showing this is the main pulmonary artery, sir, right? And at the origin of the left pulmonary artery, sir, the diameter is markedly decreased, sir, around 3.5 mm compared to the distal diameter of around 8.1 mm, sir. And even in this 3D reconstruction also, sir, we can clearly see that the origin of the LPA from the MPA is at an angle, sir, and the origin itself is quite stenosed, sir.
Okay, I think, Srinivas, I think we have to stop the case discussion
Sir.
now and then probably proceed with your talk.
Yes, sir. Sure, sir.
Okay. I think it has been a good attempt and candidate has done pretty well, barring few hiccups. I'm sure he's going to make it up in due course of time.
Thank you, sir.
Nice, Shailesh.
Well done, Shailesh. As sir has said, there are some areas which you need to improve, especially in understanding of ECG and X-ray, where sir has made some very important observations. Please bear them in your mind and work on that.
Thank you, sir.
Sir, thank you, sir. I will.
Yeah, you can go ahead and then start your.
Yeah, you have to, I think, stop sharing, Shailesh, then.
Yes, sir.
You have to stop sharing your screen. Then only I think I can.
I think I stopped this, sir.
So some technical person should be able to help him.
Sir,
You have to.
I'll stop. Sir. I'll do it.
Screen should be stopped from being shared.
Not able to.
So as to enable me to share. Yeah.
Sir, I did.
Yeah. No. Yeah. Just give me a little. Where should I? No, sorry. Where should I find my PowerPoint to be shared? How do I share this?
Sir, you can see share screen, green icon.
1 minute. Share screen. Yeah, green icon I have seen.
Yeah, please click that.
Yeah, I'm clicking. Then I'm not getting PowerPoint. Where do I find that?
You can select desktop, sir. Desktop and share.
Desktop. Yeah, desktop.
Once you click, share.
Yeah. Now I think.
Yeah, we can see. You can maximize your screen.
Yeah, I do. Yeah. Just give me.
Yeah, perfect.
Thank you very much. Thank you, sir. Thanks for this honorable opportunity for me to give this talk. Dr. Sudeep, I think you were there when
Yes,
I
sir.
started this, so it may be a repetition, and if you feel bored, you may as well. You are free to.
Nothing.
This is essentially for the students, because I thought initially we thought of talking. Second art sound. I wanted to make a presentation on second art sound, which is a very fascinating topic for me into
Yes, sir.
but then, because today's case being that we discussed a cyanotic condition, I thought this is more relevant to
Yes, sir, definitely.
repeat the same topic. Okay. So this will be ECG in cyanotic congenital heart disease, and this is as a tribute to the legendary clinical cardiologist and teacher Joseph Perloff, whose textbook on clinical recognition of congenital heart disease is a locus classicus, and it has been a guiding force and lamp in my life, in guiding light in my life in understanding clinical cardiology so far as congenital heart disease is concerned. So this is my humble, respectful homage to him. Now, ECG in congenital heart disease helps in these three ways. It is important to bear in mind that any investigation is just an extension of your clinical examination. I'm sorry. Nothing usually stands in isolation and of your clinical examination. Even ECG will give you more understanding and information only when it is interpreted in the context of your clinical science. Just now we have seen that in this case discussion. Now ECG provides structural and hemodynamic information regarding lesions, and ECG is invaluable for recognizing arrhythmias specific to certain lesions. Now, before I go into the actual topic, I would like to give a broad overview of the clinical approach to cyanotic congenital heart disease. This is how usually this kind of classification will work well in most of the situations. Cyanotic congenital heart disease with increased pulmonary blood flow or decreased pulmonary blood flow or near normal pulmonary blood flow. Now, in increased pulmonary blood flow, we will usually have either an admixture physiology or a transposition physiology. In admixture physiology, the admixture lesion can be at different levels. It could be at venous level or atrial level or ventricular level or great arterial level. And the examples being at venous level, total anomalous pulmonary venous connection, and atrial level, single atrium and tricuspid atresia. Ventricular level, it is single ventricle, and arterial level, it's truncus arteriosus. In transposition physiology, usually is represented by DTG and Tarsibum anomaly. Now, CCHD with near normal pulmonary blood flow, there are some examples, and I will not be touching these conditions in this particular talk. The more emphasis will be on increased pulmonary blood flow, and much more will be on CCHD with decreased pulmonary blood flow, especially VSD-PS physiology. Now, coming to decreased pulmonary blood flow group, there is again further subclassified into two groups, VSD-PS physiology and those with pulmonary arterial hypertension. In VSD-PS physiology, again, as we have discussed just now, it will be a dominant right ventricle or a dominant left ventricle type of VSD-PS physiology. In dominant right ventricle, the examples being the classical example is TOP, and then closely followed by a close mimic DORB subaortic VSD-PS and DTJ VSD-PS, CCTJ VSD-PS, and single ventricle of RB type with PS. In dominant left ventricle, the classical example is tricuspid atresia classical type, type 1B with PS, and single ventricle of LV type and pulmonary atresia of intact ventricular septum. And the cyanotic congenital heart disease, decreased pulmonary blood flow with pulmonary arterial hypertension is Eisenmenger syndrome. This again, I am not considering in this particular talk. Now, going back to this slide, as we have seen here, the examples of increased pulmonary blood flow are TAPVC, single atrium, tricuspid atresia, and single ventricle truncus arteriosus and DTGA. So in that order, I will be discussing briefly their ECG findings. As I would like to re-emphasize the point that ECG is useful only in the context of the clinical examination. So, for instance, TAPVC is a right heart volume overload situation, an unobstructed TAPVC. So it will have the ECG will just resemble like a septal OS ASD's large secondum ASD ECG. So this is what I would like to emphasize. So ECG will help you only in the when it is taken along with the clinical examination findings, not in isolation. But there are certain situations where just by looking at ECG like a spotter, you can make the diagnosis also. That also will presently see. So TAPVC, it will resemble a secondum ASD. Usually the TAPVC will have a large non-restrictive ASD. So there will be right axis deviation, right ventricular hypertrophy, which is represented by tall R waves in right precordial leads and inverted T waves and deep S waves in the left precordial leads. And right atrial enlargement also will be there. I am sure you will know, the criteria for this chamber enlargement on ECG. Now here you see there is a RBVB type RVH with right axis deviation in the limb leads. And now coming to common atrium. Common atrium is a situation where there is no interatrial septum at all. So there is a deficiency of sinus venosus septum, secundum septum and primum septum. So ECG will show the features of the deficiency of all these parts of the septum. So there is a total deficiency of the atrial septum. So there will be left axis deviation of the P wave with inverted P wave in inferior leads. This is due to the sinus venosus septal deficiency, which will cause hypoplasia of the regular sinus node. And there may be absence of regular sinus node. There may be in inferiorly located ectopic sinus node. So this is represented by upright T waves, inverted P waves in the limb leads, so inferior leads, leading to left axis deviation of the P wave. And there will be counterclockwise loop of the and left axis deviation of the QRS. This is due to ostium primum septal defect. And there will be right ventricular hypertrophy due to the deficiency of the ostium secundum atrial septum. So there will be signs of sinus venosus ASD, primum ASD, as well as the secundum ASD. There will be left axis deviation of P wave as well as QRS with the counterclockwise loop of QRS. And then there is a right ventricular hypertrophy. When you see an ECG like this, you can strongly suspect the condition to be a common atrium. So here you can see there is small Q wave in L1 as well as AVL, and there is left axis deviation here, or rather in northwest axis, and with right ventricular hypertrophy, and there is inverted P waves in Q3 AVF suggesting left axis deviation of the P wave. So this is left axis deviation of P wave, left axis deviation of QRS, and the counterclockwise loop of QRS with the right ventricular hypertrophy. And then coming to the tricuspid atresia, I'll deal with when I talk about VSDPS group. So truncus, there will be biventricular hypertrophy and biatrial enlargement. So ECG reflects the same. There will be right atrial enlargement, left atrial enlargement, and QRS will show when there is increased pulmonary blood flow. Initially, there will be left ventricular volume overload and LV dominance will be there. When you have either PS or severe pulmonary arterial hypertension with Eisenmengeration, there will be decreased pulmonary blood flow with right ventricular dominance, and ECG will be there because of underfilled left ventricle and systemic right ventricle. Usually, there will be biventricular hypertrophy signs like in a large VSD with Katz-Vactal phenomenon in the mid-precordial leads. So here you can see there is a LV volume overload, LVH will be there, and there is RVH here, and there is clockwise loop with inferior axis. So here you can see there is biventricular hypertrophy. There is then what you call the right atrial enlargement. And then we'll go to transposition of great arteries with non-restrictive VSD. Again, ECG will simply resemble ECG of a VSD. So right axis deviation will be there, or inferior axis will be there. LV volume overload with the deep Q waves and well-developed R in V6, and biventricular hypertrophy, large RS complexes in mid-precordial leads will be there. And PAH, as PAH increases and Eisenmenger develops, it evolves into pure right ventricular hypertrophy with the right axis deviation. So here you can see there is right ventricular hypertrophy, there is left ventricular hypertrophy with well-developed Q wave and mid-precordial increased voltage suggesting biventricular hypertrophy with right atrial enlargement and left atrial enlargement. So you just by seeing at this ECG, you cannot say whether it is a pure, simple isolated large perimembranous VSD or a single mid-muscular VSD or a DTJ with a large VSD or a truncus. This is what I am trying to say. So you should always interpret ECG in the context of the clinical science and clinical picture. Now, when you sometimes use TGA, the intercirculated mixing may be only at the level of atrial septum with a large ASD, then it will simply resemble an ASD ECG. Now, DORB subpulmonic VSD is similar to DTGA physiologically. So here again, there will be large subpulmonic VSD So ECG, you expect it to show in the similar way as an isolated VSD will show. Now, tricuspid atresia sometimes can have a large VSD, usually associated with detransmission of the great arteries. Here, because of large VSD and increased pulmonary blood flow, morphological right ventricle also is rather well developed. Unlike in a tricuspid atresia, which is classical type, where there is a restrictive VSD and hypoplastic RV, where LV is dominant. Here, there is a kind of RV development also is well preserved. So RV forces are also well developed on ECG. So you don't get a counterclockwise loop and left axis deviation like you get in a classical tricuspid atresia with PS, but you will get an inferior axis with clockwise loop and well-developed RV forces on ECG. Now we'll go to VSD-PS physiology. This is one group where ECG is very useful to differentiate similar lesions. So the classical example, as you all know, is a tetralogy of Fallot with PS. So here the ECG will show normal or peaked P wave with normal PR interval. The normal PR interval in an unoperated patient, especially usually it will be PR interval will be normal. And sometimes in a post-operative patient, there may be prolongation of the PR interval. So clockwise loop with right axis deviation, and as we have just now discussed, right axis deviation usually only is in the range of 110 to 120 degrees. And more right axis deviation in the setting of TOF is to be expected only when there is a pulmonary atresia. Up to 150 degrees, it may be there. Clockwise loop will be there, which means there will be Q waves in inferior leads, but not in L1 AVL. Normal QRS duration. So all these points are meaningful because you expect a QRS to be wide in limb leads, especially in a DORB subverted PS. You expect an PR interval to be prolonged in a DORB subverted. That's why I'm making a special emphasis on their normalcy in TOF also. Right ventricular hypertrophy is characterized by tall monophasic R waves with no evidence of strain. And there is an abrupt change from monomorphic R wave in V1 to RS pattern in V2, suggesting an early transition in TOF. This is a very typical for TOF. And there is RS pattern V2 to V6. Yeah, here I have also mentioned there is an absent Q waves. Sir has just now highlighted this point during the clinical case discussion. Absent Q waves in V5 to V6 because of underfilled left ventricle. And here you can see, again, you see there is no Q wave in V6. In a TOF patient with normally positioned morphological left ventricle, and there is monophasic R in V1 with early transition into V2, and there is a clockwise loop suggested by Q wave in L3 and also AVF and a significant right axis deviation. This is a classical for TOF. Just by seeing at this ECG, we can say we are dealing with a TOF patient. So this is another example of TOF ECG. You can see a monophasic R wave with, you see very clearly early transition is occurred. There is no Q wave in V6. There is clear-cut clockwise loop due to deep Q waves in L3 and AVF and a significant right axis deviation. So this is a classical TOF with PS. Now, there are some variations upon these classical ECG findings even in TOF, where you can get a left axis deviation with clockwise loop in TOF, left axis deviation with counterclockwise loop in TOF. Now, there are some causes for left axis deviation with the loop being retained in the clockwise pattern. They are in a patient with TOF with severe AR, where LV forces have developed well, LVH has developed, and hypertension. When there is a large PDA with LV volume overload, TOF with pulmonary atresia with large MAPCAS causing LV volume overload may occur. RV with strain pattern, RVH with strain pattern. So all these suggest prolonged PR interval, RVH with strain pattern, then counterclockwise loop with left axis, right axis deviation strongly go in favor of DORB subverted VSD and PS. Now, another example of VSD-PS with RV dominance we have just now discussed is DTJ VSD-PS, where you will again get a clockwise loop with right axis deviation like in TOF, but the differentiation from TOF is RVH with strain. You don't get strain in TOF, but in DTJ VSD-PS, though the loop and axis may be similar to TOF, but the V1 will give away the diagnosis in the form of a strain pattern with RVH. There are some important overarching concepts we need to understand so far as conduction system and complex congenital heart disease is concerned. One important point is formation of the crux which is the meeting point of the both AV valve rings and the intraventricular septum and the interventricular septum. The posterior location of the heart is called crux. This formation of crux is essential for the location of the regular AV node in the posterior position, and for it to make a connection with the non-branching portion of the bundle. This is very important. We'll see presently. Why so? The crux may not be formed and crux may be violated in certain situations. In CCTJ, though the intraventricular septum, interventricular septum, they both meet, and also both AV rings are there. There is an angulation, malalignment between the intraventricular septum and interventricular septum. The malalignment of both septae causes problem in the crux. Hence, the regular posterior AV node will not be present. Even if it is present, it is hypoplastic and it will not make connection with the non-branching portion of the bundle. Rather, an anterior accessory AV node will be present, which will make connection with the bundle. Similarly, so regular posterior AV node may not be present in some examples of the single ventricle where the ventricular septum does not reach the crux at all. So the crux is not formed when the IVS doesn't go to the posterior location and meet with the interventricular septum and the AV rings there, AV valve rings there. In this situation also, an anterior accessory AV node will connect with the bundle, not the regular posterior AV node. Now, L transposition or CCTJ with VSDPS, where there is a double discordance. So there are three major ECG features in CCTJ. One is the disturbances in conduction and rhythm are to be expected. QRS and T wave patterns that reflect the ventricular inversion, and modification of the P wave, QRS and ST segment and T wave are caused by the coexisting congenital heart disease like large VSD, severe left atrial valve regurgitation, or severe associated LVOT obstruction or PS here. Now, coming to conduction system in CCTJ, I would like to make a few mention a few points here. As I just now said, there is a malalignment between atrial septum and the inlet ventricular septum. Hence, the regular AV node does not make contact with the infranodal right and left branches. So, an anomalous anterior AV node connects with the bundle, which penetrates the atrioventricular fibrous annulus and descends upon the anterior aspect of the ventricular septum. This is also another important variation from the normal. And non-branching portion is long and crosses the LVOT there. An Epstein anomaly, Epsteinoid malformation of the left AV valve with left-sided axillary pathway may be sometimes present, and it provides a substrate for left-sided pre-excitation between morphological left atrium and morphological right ventricle. Now, this is the cartoon which shows an anterolateral AV node. Hello? Am I audible?
Okay, sir. Okay, sir. Okay, sir.
The anterolateral AV node which crosses anteriorly over the anterior-superior margin of the ventricular septal defect. You see here also, you see it's the another view. This is the long bundle which is crossing the ventricular septal defect anterosuperiorly. In normal perimembranous VSD, the bundle is related to the ventricular septal defect infero-posteriorly, and there will be significant muscle that separates the bundle from the border of the VSD. So when you close the VSD in a routine perimembranous VSD, it's the bundle, the conduction system is unlikely to be damaged. But here it is anterosuperiorly related to the ventricular septum, and also importantly, it is right in the margin of the ventricular septal defect. So it is likely to be damaged during surgical closure, if at all a surgical closure of VSD is done here. So that has to be borne in mind. Just 1 minute. Now, the typical ECG features of CCTG are the conduction system, that is left bundle and the right bundle, follow their respective morphological ventricles. So left bundle will be related will go with the morphological left ventricle, and right bundle will go with the morphological right ventricle. So because of the ventricular inversion, the conduction system is also inverted. The branching pattern also is inverted. So left bundle is on the right side now in a levocardia with CCTGA. So the septal initial septal depolarization is from the right to left. So that will abolish the routine Q wave in the V5, V6. Rather, there will be a Q wave in the V1 and V2. So the absence of Q wave in V5, V6 and its presence in V1, V2 is diagnostically important ECG finding and an important ECG clue for the diagnosis of CCTGA. And the loop is clockwise here, and there will be right axis deviation. And I'll make a mention here that if there is a large VSD or an intact septum with a just ventricular inversion, there will be clockwise loop with superior axis. But as the severe PS develops or pulmonary hypertension, just now as I told in DRV, again the axis becomes inferior and becomes rightward. So the loop and axis, which was discordant initially in the form of a clockwise loop with left axis deviation, will now become concordant in the form of clockwise loop with right axis deviation, CCTGA. Whereas in DRV, the initially concordant counterclockwise loop and left axis deviation in DRV subaortic VSD will become discordant with the development of right axis deviation with severe pulmonary stenosis. These are some interesting points one need to observe. And then there are upright T waves in all precardial leads that is related to the side-by-side orientation of the both ventricles due to the vertical orientation of the interventricular septum. In 75% of the patients can have varying degrees of AV conduction abnormalities. 30% of patients can have complete heart block, and incidence of complete heart block increase by 2% per year annually. Now, here there is a clear-cut Q wave in V1 and absence of Q wave in V6, suggesting inversion of the conduction system. And there are upright T waves in all the precardial leads, and there is clockwise loop suggested by L3 and AVF with right axis deviation. This is typical ECG of a CCTGA. Now coming to the tricuspid atresia with VSDPS, here we are starting VSDPS group with LV, clinically LV dominance. So here, as you see in this cartoon, there is a well-developed dominant left ventricle with a hypoplastic right ventricle and tricuspid atresia. The conduction system is essentially normal here. The central fibrous body is abnormally formed, but AV node is located normally and pierces to form his Higgs bundle. The ECG findings will be right atrial enlargement and PR, because this is because there will be prolonged intra-atrial conduction because of enlargement of both right atrium and left atrium, and there is PR interval prolongation here. There is left axis deviation, as Sarra has asked what is the cause of counterclockwise loop. There will be counterclockwise loop and left axis deviation in the tricuspid atresia due to fibrosis of the left bundle and abnormal distribution of the conduction system, which means there is unusually long right bundle and early takeoff of the left bundle, and which is close to the nodal origin of the His bundle, and which also undergoes an early arborization. So in early arborization and early takeoff of the left bundle and a long right bundle is responsible for the left axis deviation of the counterclockwise loop in tricuspid atresia with VSDPS. And because dominant left ventricle, you will expect to see a left ventricular hypertrophy. And in a small child with tricuspid atresia, the ECG will typically show what is called as adult progression of QRS. That means a small R and DPS in V1, which progresses to a Q with dominant R and a small S in V6, suggesting an LVH. So this LVH will cause an adult progression of QRS in the small child. This is very typical for tricuspid atresia. Now, as you see here, there is a counterclockwise loop in the form of Q wave in L1 and AVL. There is significant left axis deviation. There is prolonged PR interval. There is adult progression of QRS with a RS pattern in V1 and monophasic R in V6. This is typical for a classical tricuspid atresia type 1B. Now, before another important example of VSDPS is single ventricle, and single ventricle is a broad term which has different subgroups. So we need to know the conduction system in single ventricle will vary depending upon the subgroup. There can be LV morphology of single ventricle, indeterminate morphology, and RV morphology. In single ventricle of LV morphology and indeterminate morphology, the septum does not extend to the crux. In single ventricle of LV morphology, in indeterminate morphology, single ventricle is the true single ventricle where there is no septum at all. So there is no question of any septum reaching the crux. So though there is a septum in left ventricular morphology, single ventricle, it does not extend to the crux. In indeterminate morphology, single ventricle, there is no septum at all, so there is no crux. So in these two situations, we expect an well-developed anterolateral AV node, which is connected to the conduction system, but not the regular posterior AV node. Just now, as I mentioned in one of my previous slides. Why does not the septum extend to the crux in single ventricle of LV morphology? What is the septum? Septum is what is present between two ventricles. So now here, if you consider an outlet chamber as a hypoplastic right ventricle, it is attached to the main ventricle, which is left ventricle, in a anterosuperior location. The septum is ending there in the anterior portion of the main ventricle only. It is not going to the posterior portion of the left ventricle because the outlet chamber is attached to the main ventricle in the anterosuperior location, whether it is inverted or non-inverted. In both these situations, there is an anterolateral AV node. Similarly, in indeterminate morphology, single ventricle, there is no septum at all, so you will have a anterolateral AV node. In single ventricle of RV morphology, the outlet chamber or the hypoplastic left ventricle is attached postero-inferiorly. So the septum is located posteriorly and it will reach up to the crux. So septum extends to the crux, so you can expect a regular posterior AV node to be present there. Now, another important concept in single ventricle we need to understand is topology. There is what is called as right-hand topology and left-hand topology. This is nothing but whether the outlet chamber or the hypoplastic chamber is in its regular location and the right side or the left side. For instance, if it is a single ventricle of LV morphology, you expect the outlet chamber, which is of RV morphology, to be on the right side. Then it is right-hand topology. If it is on the left side and it is inverted outlet chamber, it is left-hand topology. Similarly, single ventricle of RV morphology, you expect hypoplastic or left ventricle to be on the left side. Then that is RV right-hand topology. If it is inverted, it is left-hand topology. So in other words, right-hand topology is normal position of the right and left ventricles. Left-hand topology is inverted position of the right and left ventricles. So now in RV morphology, single ventricle, usually septum extends to the crux. So in right-hand topology, there will be normal AV node in the triangle of the cock. In left-hand topology, there will be still an inlet septal remnant leading to the formation of the normal AV node. Sometimes there may not be there may not be any inlet septum even in right-hand single ventricle of RV morphology with left-hand topology. There can be an anterolateral AV node. So in other words, there will be a definitely consistently an anterolateral AV node in single ventricle of LV morphology with or without inverted outlet chamber, single ventricle of indeterminate morphology where there is no interventricular septum at all, and sometimes single ventricle of RV morphology also with the left-hand topology where the dominant RV is on the left side, there may be anterolateral AV node. So we need, and another important point we need to understand is, even if there are two AV nodes, anterolateral AV node and regular AV node in the posterior location, the anterolateral AV node will be well developed in these situations only if the right AV valve is well formed. As the right AV valve becomes more hypoplastic, the anterior AV node also will come more posteriorly, and when the right AV valve is completely atretic, the anterior AV node will come back posteriorly and merge with the regular posterior AV node. So there are some advanced concepts so far as the conduction system of single ventricle are concerned. Now this is what I have again summarized here. Single ventricle of LV type and indeterminate morphology, there will be anterolateral AV node. Single ventricle of RV type, right-hand pattern, there will be normal posterior AV node. Left-hand pattern also there will be normal posterior AV node. Sometimes you have to anticipate an anterolateral AV node. Now ECG in single ventricle. So single ventricle of LV morphology with non-inverted outlet chamber or right-hand topology, you will have a counterclockwise loop with left axis deviation. This is a close mimic to tricuspid atresia clinically. Even in ECG also, you will have a counterclockwise loop with left axis deviation of QRS like in tricuspid atresia. The only differentiating feature will be in the precordial leads, where there will be stereotyped QRS complexes in all precordial leads in single ventricle, whereas you will expect a LVH with adult progression in tricuspid atresia. Now, single ventricle of LV morphology with inverted outlet chamber, you will develop the patient will have a clockwise loop with right axis deviation, unlike in non-inverted outlet chamber, and there will be again stereotyped complexes of QRS in precordial leads, and there will be features of ventricular inversion, and like in CCTJ, you may expect to have varying degrees of heart blocks. Single ventricle of RV morphology, there can be clockwise loop and right axis deviation like in single ventricle of LV morphology with the inverted outlet chamber. So these two you cannot differentiate from ECG. There will be stereotyped complexes across all variants of single ventricle. Now this is single ventricle of LV morphology with non-inverted outlet chamber. You see clearly there is a counterclockwise loop as evidenced by Q wave in L1 and AVL, and there is left axis deviation, And there is a more or less a similar looking QRS complexes in the precordial loops. Now, this is to see the in tricuspid tree in in cyanotic congenital heart disease. This is just some thumb rule. Tricuspid atresia, you will have LVH with reduced RV forces. Pulmonary atresia, you will have LVH with intact ventricular septum. You will have LVH with the reduced RV forces, but you will have a normal inferior axis. In pulmonary atresia, with intact ventricular septum, clockwise loop with normal inferior axis. Whereas in tricuspid atresia, you will have counterclockwise loop with the superior axis. In classical TOF, you will have right axis deviation. So ECG in VSDPs, this is just an algorithm I have made. So look at the loop. So you have a clockwise loop or counterclockwise loop. Once you have a clockwise loop, then you see at the axis, either it's the right axis deviation or left axis deviation. If you have right axis deviation, the conditions that can cause a clockwise loop and right axis deviation in VSDPs are TOF, DTGA, CCTGA, single ventricle of LV morphology with inverted outlet chamber and single ventricle of RV morphology. If you have a clockwise loop with the left axis deviation, it is very rare. Usually it doesn't happen, as I told. In CCTGA version, initially to start with, the axis will be left axis deviation. Though even after the development of PS, sometimes the axis may remain as left axis deviation. This is extremely rare to have clockwise loop with left axis deviation, VSDPS. This is usually an RV dominant situation. These are the conditions that can cause this combination of clockwise loop with right axis deviation. Now coming to counterclockwise loop, if you have a counterclockwise loop, again you look at the axis, right axis deviation or left axis deviation. Usually counterclockwise loop is associated with left axis deviation. The conditions that cause this are classical tricuspid atresia, VSDPS, single ventricle of LV morphology with non-inverted outlet chamber, and DORB subaortic VSDPS sometimes can have a left axis deviation which is retained there. And counterclockwise loop, right axis deviation, one important single example will be DORB subaortic VSD and PS. So this is how you approach ECG in cyanotic congenital heart disease. Extremely valuable to differentiate conditions which are closely mimicking each other, especially in VSDPS physiology. So choose the best way of learning, and the customer will render it agreeable for you. Thank you very much.
Thank you, sir, for your this very nice talk, sir. Actually, we also get new things actually. Because we not applied most of the time, sir. Actually,
very kind of
you differentiated very nicely with the algorithm, sir. So I think it is helpful for everyone, sir. So thanks a lot, sir. Any comments, sir? Dayasagar sir and Bang sir. Sir.
I think we are already beyond the time. We are
okay, sir. Thanks a lot, sir, for your actually talk and enlighten us for that, and getting your time and enlighten all students as well as us also. So thanks a lot. I think this class initiative was very good. It's a new learning for us also.
Yes, we are all grateful to Dr. Sagar sir. Sir is an inspiration to us for all his enthusiasm and commitment to teaching and learning. So yes, sir, take a cue from him and get inspired by him. Thank you so much.
Thank you. Thank you for your time and participation. So, Dayasagar sir, any comments, sir?
Sir is there? These are left. Okay.
I think sir left. I think, sir.
Okay. Thank you.
Thank you, Lord. Thanks a lot, sir. Have a good day.
Yeah, you too. Take care, Sujit. We'll meet again. Thank you.
Okay, sir. Thanks a lot, sir.